this is on. All right, y'all. I think we'll get started. I'm excited to introduce my resident, John Lyons, today. John studied pharmacy at University of Pittsburgh. He then did first-year residency at University of Illinois, Chicago, and then he is with us. So John, he made a deal 2 weeks ago to join the University of Michigan, which really tore his soul up because he is a huge Buckeye fan. So we're very excited for John. He's very excited, but he may have to become a Wolverine fan. So good luck.
No, I'll be a Buckeye until the day I die. They may break me down, but no, I can't give that up. I'll be going to the big game every other year, so I'll be wearing the scarlet and gray for sure. Okay, good morning, everybody, and thank you for coming to our nice 8 a.m. Friday Transplant Grand Rounds. Today we're going to be talking about subclinical rejection. This has been the topic of my research as well as kind of my actual pharmacotherapy grand rounds over at the College of Pharmacy. And we're going to talk about how it relates to the sword of Damocles in renal transplant. So first of all, I have no actual or potential conflicts of interest. I'm a poor resident. I have no money, so I do not have any commercial interests at all. So today we're going to be defining subclinical rejection as well as the role of the protocol biopsy in renal transplantation. We're going to review current literature regarding the utility of subclinical rejection in both adult as well as pediatric renal transplant recipients. And then we're going to review my research, which is comparing actual outcomes of pediatric patients that had protocol biopsies versus those, a historical control cohort of patients that did not have protocol biopsies. So I'm sure when everybody saw this title, first they thought, wow, John is a nerd. And second of all, they thought, what in the world is the sword of Damocles? So the sword of Damocles is actually a parable from mythology. Actually, it's about a Sicilian tyrant Dionysius, who is a tyrant in Sicily. And Damocles was actually a servant on his court. And so Damocles was known for talking up Dionysius and saying, wow, it must be nice that you get waited on hand and foot. You know, you get all the food, all the wine, anything you want is at your fingertips. I would love to be in your shoes for one day. And so Dionysius said, well, it's not easy being the king, so, I want to teach him a lesson. So Dionysius said that if Damocles wanted to switch places with him, he could sit on his throne. However, the entire time he was sitting on the throne, a sword suspended by the single hair of a horse's tail, can't make this up, it would be suspended over his head. So Damocles agrees, and when he sits on the throne, immediately he's fearful about being impaled and this sword falling on his head. So this is kind of a story that teaches a lesson about with those in great power have great responsibility, as well as the fear of some type of impending doom for those that are in positions of power. And so hopefully by the end of this talk, we'll kind of relate this to subclinical rejection. And sorry for the nerdy mythology at 8 in the morning on a Friday. So, in renal transplantation, probably one of the most important outcomes, one of the biggest outcomes we look at is renal transplant rejection, specifically in the first year. This is a complex multifactorial process. It involves components of both the cellular as well as the humoral immune system. However, in the first year, and we've done a pretty good job in our first year rejection rates at less than 15% since about the mid to late 90s, and our 1 year graft survival rates of greater than 90%. However, our long-term graft survival between 5 and 10 years post-transplant has seen a pretty steady drop to about 50% at 10 years post-transplant. Now, most of these graft loss, our leading cause of graft loss is cardiovascular death with a functioning graft. However, our second leading cause of graft loss is chronic rejection, and it's more aptly named now chronic allograft nephropathy or interstitial fibrosis and tubular atrophy. So chronic rejection is known as this progressive decline in allograft function and involves immunologic as well as non-immunologic factors, and that's why that name was changed from chronic rejection to more chronic allograft nephropathy or CAN in interstitial fibrosis and tubular atrophy or IFTA, which is what you would see histologically. So since chronic rejection implies more of an immunologic cause, when you look at our risk factors, seeing that there are both immunologic as well as non-immunologic risk factors for chronic allograft nephropathy, you can see that chronic rejection probably isn't the most appropriate name for this insidious pattern of graft damage and eventual graft loss. And if you can see in the bottom corner down there, subclinical rejection is one of those risk factors for chronic allograft nephropathy, which we'll talk about later on in the presentation. So currently we don't have any specific treatment for chronic allograft nephropathy. The best treatment really is prevention. So identifying and treating our acute rejection episodes, chronic disease state management, hypertension, hyperlipidemia, as well as diabetes post-transplant, optimization of our immunosuppression, not too low, not too high, as well as medication adherence, and a shameless plug for our pharmacists who work with patients to help with medication adherence. So within renal transplantation, probably the most common marker that we use to measure graft function is serum creatinine, and for good reason. It's inexpensive, it's easy to use, and trends in serum creatinine give us a good idea of how a graft is functioning over time. However, serum creatinine is by no means a perfect marker, especially in a transplanted kidney. It has many disadvantages, specifically high interpatient variability. There's also some intra-lab variability, which has sustained despite a national, actually international effort to standardize creatinine assays. And it's not very sensitive or specific for a specific pathology that may be going on. We've tried some other strategies such as cystatin C, 24-hour urine creatinine collections, as well as protocol biopsies, which brings us to our next topic, the protocol biopsy. Another name for it is a surveillance biopsy, and by definition, it is exactly what it sounds like. It's a biopsy that's done at a pre-specified time point. It's done without regard to renal allograft function, without a change or a clinically significant change in renal function. And it's by no means something that many transplant centers utilize. A recent survey of transplant centers showed about 18% of centers actually utilize protocol biopsies in the adult population. So much like serum creatinine, the protocol biopsy has its own advantages and disadvantages. Disadvantages being it's invasive. If I were a transplant patient myself, I would not want to be biopsied more than I need to. I wouldn't want that needle stuck in me more often than I need to. There is a low risk of complications, sampling error, there may be pathologist variability. There is some cost implications. This isn't a free procedure, as well as quality of life, as I mentioned earlier. Some advantages of surveillance biopsies is it can find incidental findings, specifically with drug toxicities. It can catch, our subclinical rejection, which we'll talk about in a minute, as well as identifying any early clinical rejection, as well as tracking chronic changes in the allograft over time. Which brings us to the topic of the hour, subclinical rejection. So subclinical rejection, by definition, are histologic features of acute rejection on renal biopsy based on the Banff criteria in the absence of a clinically significant decline in renal function. Now, clinically significant decline in renal function, is kind of a point of contention, especially across many studies that have looked at subclinical rejection, mainly because there's no defined threshold in terms of what one would consider a clinically significant threshold. Is this a 10% change in GFR? Is this a change in GFR of 10 mils per minute, 5, 15? Many studies have different definitions historically, so there really hasn't been much consensus in that. The highest prevalence of subclinical rejection is typically within the first 6 months post-transplant. The highest incidence is about 30% at 3 months, which declines to less than 10% by 12 months post-transplant. From a pathophysiologic standpoint, subclinical rejection is very similar in nature to acute rejection, and the way I like to make sense of it in my head is it's just like an acute rejection, but on kind of a smaller scale. So there are lower levels of chemokines, cytokines, pro-inflammatory factors, and cytotoxic lymphocyte products that kind of lead to graft damage, but not necessarily manifest as a change in serum creatinine. Some risk factors for subclinical rejection include class 2 HLA mismatch, prior sensitization, previous rejection episodes, as well as one study had found an association of using basiliximab or interleukin-2 receptor antagonists as an induction immunosuppression being associated with subclinical rejection. And if you look at these risk factors, and if you go back to my earlier slide with the risk factors for chronic allograft nephropathy, many of these overlap. So subclinical rejection has actually been correlated with the development of clinical acute rejection episodes. A single study has found that patients that had subclinical rejection on an early surveillance biopsy went on to develop a clinical acute rejection at 12 months post-transplant. And it's also been linked to early chronic damage leading to chronic allograft nephropathy. So this is where the kind of parable of the sword of Damocles comes in. So subclinical rejection is something that we don't see typically unless we're looking for on a surveillance biopsy. So really it's kind of right now this sword that's hanging over our heads, waiting for it to fall in either a clinical acute rejection episode or development of chronic allograft nephropathy leading to early graft loss. So by characterizing subclinical rejection, defining it, figuring out what kind of risk factors and what kind of cytokines, chemokines, and other inflammatory factors are going on with this pathology, we've kind of defined our own sort of Damocles. We found this insidious, behind-the-scenes pathology that our serum creatinine really isn't picking up too well, and we're only finding on surveillance biopsy. So not only have we identified our sort of Damocles, but we've practically hoisted it above our heads. And when we find it on surveillance biopsy, we feel compelled to do something about it. So in the cyclosporin era of immunosuppression, a single study has demonstrated benefit of treatment of subclinical rejection with IV pulse dose steroids, solumedrol. And they found that patients that were treated had superior renal function at 2 years post-transplant. They had a lower incidence of acute rejection episodes, as well as less chronic damage based on the Banff score on their biopsies. However, the one big limitation of this study is that all patients were treated with cyclosporin. Now, when I had mentioned that early post-transplant, we have this incidence of about 30% of subclinical rejection within 3 months post-transplant, these were in studies that were done exclusively on patients treated with cyclosporin, which we know it has a much higher incidence of subclinical rejection. And right now, we don't use cyclosporin much at all. About 90% of centers across the US, and especially our center, we do not use cyclosporin. Now, there was a single study in the tacrolimus era of immunosuppression that characterized subclinical rejection as having a much lower incidence than that of the cyclosporin era, at about 6 to 8% within the first 3 months post-transplant. The only exception to this are high immunologic risk or high-risk patients, specifically our positive cross-matches, as well as our ABO incompatible. And with our positive cross-match patients, they found an incidence of subclinical rejection at a much higher rate, actually higher than that of the cyclosporin studies, and ABO incompatible found much more significant chronic damage on biopsy rather than subclinical rejection. Which brings us to the clinical question of our talk today. Is it worthwhile to treat subclinical rejection in modern renal transplantation, knowing that our tacrolimus-treated patients have a lower incidence, based on this study, have a lower incidence of subclinical rejection? So we're going to be looking at 3 different studies today to see if our sword of Damocles really still exists in modern renal transplantation. We're going to be talking about Key and colleagues from 2006, Zetterkenny and colleagues in 2011, as well as Gigliotti and colleagues from this past year. So the first study that we're going to be talking about is Key and colleagues. This was a single-center retrospective study that evaluated the incidence of subclinical rejection at 3 months post-transplant, as well as the effects of early treatment of subclinical rejection. This included both kidney as well as kidney pancreas transplant recipients that had protocol biopsies done at both 1 month and 3 months post-transplant. All patients within the study cohort also had a follow-up biopsy at 12 months, which was part of their standard protocol within their center. All patients had to have CNI-based immunosuppression, and before I go further with any of the other studies, the reason that these 3 studies specifically were included was because they had at least 50% of patients treated with tacrolimus in the arm. So although it's not 100% tacrolimus-treated patients, really based on a literature search and even a more recent literature search, in the adult patient population, really don't have any of these studies that are exclusively in tacrolimus looking at specifically the treatment of subclinical rejection, just as an aside. So going to our exclusion period, since this was retrospective, patients essentially that didn't have their 1 and 3 month surveillance biopsies were not included within the study cohort. For immunosuppression, this was actually an Australian patient population, so they received either no induction or basiliximab induction. They received tacrolimus or cyclosporin, as well as Cellcept, as well as prednisolone. For subclinical rejection, I listed some of the main categories in terms of how they treated subclinical rejection. Again, bringing up the fact that this is a retrospective study, they really kind of just characterized everything that they did. And as you see, you'll see in a few slides, there were many different flavors in how they treated subclinical rejection in their study cohort. But the main kind of trends that we saw were pulse dose steroids or IV methylprednisolone, 500 milligrams a day for 3 days, or an actual oral pulse of prednisolone oral steroid taper down to their baseline immunosuppression, or just an overall increase in their baseline immunosuppression. Some patients were also switched from cyclosporin to tacrolimus in this cohort. Their main primary outcome of interest was subclinical rejection at 1 and 3 months post-transplant. Looking at our baseline characteristics, many of the patients were well matched with the exception of a few key differences, which I've listed here on this slide. First of all, the patients that were treated with tacrolimus had a higher incidence of diabetes pre-transplant. They had a higher HLA mismatch at baseline. More of these patients were deceased donors, and they also had a longer ischemic time in comparison to the cyclosporin arm. So already our tacrolimus-treated patients were probably at a higher risk for chronic allograft nephropathy, early rejection post-transplant, just at baseline. Looking at the incidence of subclinical rejection, they found almost a 50% incidence of subclinical rejection. And this was fairly well balanced between actually our tacrolimus and cyclosporin-treated patients. The highest incidence that they found subclinical rejection was at 1 month, with the remaining at 3 months and then 12 months, with 25% at 1 month. And then, like I said, looking at subclinical rejection based on the CNI used at baseline, 17 cyclosporin-treated patients had subclinical rejection and 15 tacrolimus-treated patients. So there's no significant difference between the two groups. There were only 2 biopsy-related complications. They were not deemed to be clinically significant. One was an AV fistula that resolved spontaneously, and the other was simply just transient hematuria, which spontaneously resolved after a few voids. So looking at our different treatment modalities for subclinical rejection, you can really appreciate with this chart here how many different strategies they utilized within the study cohort. So the most common was treatment was really a pulse steroid regimen as well as increase in their baseline immunosuppression. Some patients were switched from cyclosporin to tacrolimus. Some were really just increase their baseline immunosuppression, and actually many patients were not treated at all. Looking at the actual surveillance biopsy results and kind of the damage that they were seeing based on the acute as well as chronic Banff scores, they found a higher incidence of chronic graft damage in patients that had subclinical rejection and 1-month protocol biopsies. And treatment of this, the patients that were treated, they actually found a decline in their inflammation as well as their chronic graft damage on 3-month biopsy. And those patients that were not treated that had early chronic changes on their 1 and 3-month protocol or their 1-month biopsy actually had an increase in their chronic biopsy scores at 12 months post-transplant. So basically what we can conclude from this is that treatment was able to actually control some of this early chronic damage that they were seeing on these surveillance biopsies. So the authors concluded that subclinical rejection was common in the study cohort. It was associated with early chronic damage, and that treatment was able to stabilize this damage. So my critique of this, looking at our strengths, so obviously it included about 50% of patients had tacrolimus-based immunosuppression. So obviously we really weren't able to tease out any studies that had specifically only tacrolimus-treated patients. So having at least a decent chunk of the cohort being treated with tacrolimus gives us an idea of our incidence of subclinical rejection as well as the benefit of treatment post-transplant. There are also a wide variety of methods for treating subclinical rejection. Now, I listed this both as a strength as well as a limitation because I think this can be a double-edged sword. So obviously, since this was a retrospective study, they really just listed every way that they treated subclinical rejection. However, because of this, we can see that some treatment is better than no treatment. However, we don't really know what our best treatment or what the standard treatment regimen that should be utilized in these patients is because there were so many different ways that they were treated. Other limitations include a small sample size. As I've probably said ad nauseum in the past few minutes, it's retrospective analysis. It was a pilot study, primarily observational in nature, and they really didn't stratify their treatment based on the CNI that they used at baseline. I would have liked to have seen if there was any difference in how the cyclosporin-treated patients were treated in comparison to the tacrolimus-treated patients. Yes? So they did stratify it based on the antibody and as well as the cellular acute rejection. Majority of the episodes were cellular acute rejection. So they just had subclinical. They didn't even define borderline within their cohort. So what we can conclude from this is that protocol biopsies, if they're going to be done to capture subclinical rejection, they should be done within the first 3 months post-transplant. And the treatment of subclinical rejection was able to have an impact on the progression of chronic damage within the graft, and the optimal treatment of subclinical rejection at this point really is unknown. So moving on to our second study, Zetterkenny and colleagues from 2011. This is a single-center prospective randomized trial that evaluated the benefit of both early and late protocol biopsies and wanted to look at the impact of protocol biopsies on allograft function at 2 and 3 years post-transplant, as well as 5-year graft survival. They included patients that were adults receiving a kidney transplant. They had to have stable graft function, which was defined as a serum creatinine less than 3.3 at 3 months post-transplant. They had to have no clinical symptoms of rejection, as well as CNI and MMF-based immunosuppression. Stable immunosuppressive trough levels, as well as good compliance to treatment. So even looking at the inclusion and exclusion criteria, I have some eyebrows raised. Serum creatinine of less than 2.3 or 3.3 really doesn't sound like stable graft function to me, and good compliance was not defined by the study investigators. So when they included patients, they actually randomized them to either 3-month protocol biopsies, 12-month protocol biopsies, or 3 and 12-month protocol biopsies, or a control cohort. All subclinical rejection episodes were treated with steroid pulse therapy, and for induction, they either received rabbit antithymocyte globulin or thymoglobulin for patients that they deemed by the study investigators to be high risk, again, not defined. Everybody else received basiliximab or interleukin-2 receptor antagonists. They received dual therapy immunosuppression with tacrolimus or cyclosporin, as well as CellCept. Their endpoints, their graft function endpoints, were at 3 months, 1 year, and then annually up to 5 years post-transplant. However, they only reported up to 3 years within the results. They also described the results of the protocol biopsies, as well as biopsy-related adverse events. So looking at our baseline characteristics, these cohorts were actually fairly well balanced in regards to baseline characteristics based on immunologic as well as just their demographic characteristics. However, in comparison to our other study, one thing to note is these patients had a longer ischemic time, a significantly longer ischemic time, just looking back at Key and colleagues, which is more of like 7 and 11 hours. And as you can see, a majority of patients received basiliximab induction. They identified 65 cases of subclinical rejection by 1 year post-transplant in the surveillance biopsy cohort. All were treated with pulse steroids. If I didn't mention before, they really didn't define how they dosed pulse steroids, whether this was an IV pulse, an oral pulse, which we had seen in Key and colleagues, doses, any duration, any of that. They had 7 biopsy-related complications, which was a little bit more than we had seen in previous studies. However, these were not deemed to be clinically significant by the study investigators, majority of them being transient hematuria. Looking at our renal function outcomes, at 1 and 2 years post-transplant, you really don't see a significant difference in estimated GFR. However, at 3 years post-transplant, there was a significantly higher eGFR at 3 years post-transplant in the biopsy group in comparison to the patients that did not have biopsies. So the authors concluded that protocol biopsies are useful for renal transplant graft as well as immunosuppression monitoring, and that treatment of subclinical rejection can preserve long-term graft function and actually improve long-term graft survival. Some strengths of the studies: it is prospective and randomized. All subclinical rejections were assumed to be treated the same with their quote-unquote pulse steroid therapy. They had long-term follow-up as well as inclusion of patients and randomization to tacrolimus and cyclosporin, so they made sure that they were even between the 2 groups, and it was just greater than 50%. Some limitations: because it was a single-center study, small sample size. This was also a European patient population, so lower immunologic risk than our patient population here in San Antonio. They really didn't define what graft dysfunction was in terms of defining subclinical rejection versus a clinical rejection episode. They didn't have predefined outcomes, and they didn't stratify any of the results based on the CNI used. Additionally, I found it interesting that they had no stratification of results based on the protocol biopsy regimen that these patients were randomized to. And their use of pulse steroids can be seen as ambiguous. As a pharmacist, I'd like to see numbers in terms of doses and duration. So what we can draw from this study is that protocol biopsies as well as treatment of subclinical rejection can be potentially beneficial in long-term graft function. We're talking greater than 2 years post-transplant. And treatment of subclinical rejection really has no impact on 1 year graft function post-transplant. However, these results are based on some glaring limitations of this study. They're highly hypothesis generating. Moving on to our final study in the adult world is Gigliotti and colleagues, just published this past year. So this is a single-center retrospective study looking at the incidence of subclinical rejection at 1 month post-transplant, as well as early factors involved in subclinical rejection. So they actually did a logistic regression analysis to see independent factors associated with the development of subclinical rejection. And then finally, they also evaluated how the incidence and treatment of subclinical rejection impacted long-term graft survival. All these patients were deceased donor kidney transplants that had protocol biopsies done at 30 days post-transplant. These patients all received basiliximab induction. They received either tacrolimus or cyclosporin, CellCept as well as prednisolone for their primary immunosuppression. Subclinical rejection as well as rejection episodes were all treated the same with IV solumedrol 250 milligrams per day for 3 days for patients that had subclinical rejection. And for those that actually had a clinical acute rejection, they had IV solumedrol 500 milligrams per day for 3 days. Their primary outcome of interest was 10-year graft survival, and then, as I mentioned before, they did a multivariate logistic regression analysis to identify factors associated with subclinical rejection. Looking at our baseline characteristics, this patient population was also fairly well matched. I found it interesting that they reported their baseline characteristics in subclinical rejection versus no acute rejection. However, we were able to tease out one important thing about the patients that had subclinical rejection or developed subclinical rejection was that a higher incidence of patients, a higher amount of patients had delayed graft function in the subclinical rejection arm, which they defined actually as the number of days on dialysis, and they stratified that there. So a higher proportion of patients had delayed graft function and went on to develop subclinical rejection in that arm. As you can see here, about 65% of patients were treated with tacrolimus. So we're getting closer to modern day practice, but not quite there yet. So they found that 10.7% of patients developed subclinical rejection. This was actually fairly well balanced between the cyclosporin and the tacrolimus arms. All of these were treated with pulse dose steroids. In their multivariate analysis, they found that donor age as well as delayed graft function were associated with the development of subclinical rejection. When looking at 10-year graft survival, there was no significant difference between the subclinical rejection and the normal histology groups. In terms of graft survival at 10 years, it was about 67% in the subclinical rejection arm and 74% in patients with normal histology. And there was a significantly lower 10-year graft survival in patients with acute rejection. So we're talking 31% in that arm. So that was a fairly eye-opening difference between the three groups. There were only 4 biopsy-related complications, much in line with previous studies. These were not deemed to be clinically significant by the study investigators. So the authors concluded that protocol biopsies performed at 1 month post-transplant is useful to detect subclinical rejection, and that the treatment of subclinical rejection with low-dose IV pulse steroids improves kidney transplant graft survival in the long term, specifically at 10 years post-transplant. Some strengths I see with this study is we do have a specific regimen in how these patients were treated with a lower dose of pulse solumedrol for 3 days. There was a higher proportion of patients treated with tacrolimus, which is closer to mimicking clinical practice, and there's a very long-term follow-up. This is the longest-term follow-up I've seen in any study that looks at subclinical rejection. Limitations was I would have liked to have seen actually graft function as opposed to graft survival in the long term to see if these previous studies, the findings in terms of higher graft function at 3 years post-transplant holds up in this cohort. The external validity is somewhat limited. This was an Italian patient population, relatively low immunologic risk. It's retrospective in nature, and there was no true control group for direct comparison of treatment versus no treatment and how those patients did. However, what we can conclude is that treatment of subclinical rejection is associated with similar graft survival to patients that had normal histology. Probably the most profound thing that I saw from this, or I drew from this, was that essentially patients that were treated for subclinical rejection and were found to have it early post-transplant were treated. In the long run, they did just the same and acted just as if they never had an acute rejection episode at all, or if they never had a subclinical rejection. However, patients that had clinical acute rejection had a fairly profound detriment in their long-term graft survival. So just to bring it all back for our adult patient population, we had Key and colleagues, which used triple therapy immunosuppression in a low to moderate immunologic risk patient population, basically showing that protocol biopsies, if they're going to be done for looking for subclinical rejection, they should be done early, within 3 months post-transplant. Treatment of subclinical rejection can control their chronic graft damage that they find. Zetterkenny and colleagues used dual therapy immunosuppression in a low to moderate risk immunologic risk patient population and showed that subclinical rejection may have a beneficial long-term impact on long-term graft survival. And then finally, Gigliotti and colleagues, as we had just talked about, used triple therapy immunosuppression in a low to moderate immunologic risk patient population and showed that patients that had subclinical rejection and were treated for subclinical rejection acted very similarly in the long term to those that had normal histology. So my recommendations, before we switch over to my research, is that subclinical rejection, if we're looking for it, it should definitely be treated. It should be treated with a standard pulse regimen that we would use for our rejection episodes of either could utilize the lower dose strategy of Gigliotti and colleagues of 250 milligrams of Solu-Medrol for 3 days or 500 milligrams, and then obviously optimization of immunosuppression. So one of the things we need to make sure is that at the time of these subclinical rejection and these biopsies, that patients are actually therapeutic on their prograft levels and are actually taking their medications. I think it's beyond the scope of this talk. When I gave my talk to the pharmacotherapy grand rounds, I did make a recommendation on protocol biopsies in terms of whether or not they should be done and when they should be done, but I figured I'd ruffle some feathers in the front row, Dr. J. But I think that if protocol biopsies are going to be done, they should be done earlier rather than later post-transplant. And I think that the jury is really still out there in terms of whether or not protocol biopsies should be done across the board. I think in our higher risk patient populations, there has been demonstrated some benefit to tracking these patients. However, I don't know if the data is compelling enough to say that we should be doing it across the board. So now moving on to my research for the past year, we actually are hopping from the adult world over to the pediatric world, looking at the impact of 6-month surveillance biopsies in pediatric renal transplant recipients. And I'm going to go over a few studies a little bit more briefly than the previous studies that talked about the use of protocol biopsies and treatment of subclinical rejection in our pediatric patient populations. So the first study that I identified was Himes and colleagues. This was done in 2007. This is a single center retrospective study that looked at the incidence of subclinical rejection at 3 months post-transplant, as well as evaluated whether or not there was any impact on 1-year graft function. These patients were all induced with basiliximab, and they received triple therapy immunosuppression. All patients were treated with tacrolimus-based immunosuppression. And then if they were found to have subclinical rejection on their surveillance biopsy, they were treated with a pulse of Solu-Medrol, followed by a prednisone oral taper, and then tapered down over a week after these 2 taper regimens down to their baseline dose. Looking at our baseline characteristics, the patients were well matched. About 50% or greater were deceased donors, majority Caucasian. And looking at our tacrolimus troughs, there was no significant difference actually at the time of the subclinical rejection between the 2 groups. So what Himes and colleagues found was that there was an incidence of about 44% of subclinical rejection within their study cohort. And looking at their serum creatinine as their surrogate marker for graft function at 1 year, there was no significant difference between the patients that had subclinical rejection and were treated and had no subclinical rejection. So what we can conclude from this is that there was a fairly high incidence in the pediatric patient population. Previously, it had been characterized similar to what we see in the cyclosporin era in the pediatric patient population, and that treatment of subclinical rejection had no significant difference in allograft function at 1 year post-transplant. However, long-term follow-up is definitely warranted with this study, which is a common theme in many of these studies. Another study that I looked at was Kanzelmeier and colleagues to kind of set the tone for the study that we conducted here at UH. So this was a single center prospective study looking at the impact of targeted interventions on 6-month protocol biopsies with regards to graft function long-term in pediatric patients. Patients that were included in the surveillance biopsy arm basically did not have any contraindications to having a biopsy. So all patients in their exclusion criteria were actually shunted over to their control cohort. So if they were on anticoagulant therapy, there was technical complications for the biopsy. They were followed outside the study center or had an underlying psychiatric disorder. This comprised the control group. These patients either received no induction or basiliximab induction, cyclosporin as their primary CNI for immunosuppression, as well as Cellcept or everolimus as their antimetabolite of choice, and then prednisone. For acute rejection, these patients were treated with a pulse of prednisolone IV, and then an increase in their cyclosporin levels or switch over from cyclosporin to tacrolimus. And then if they found borderline changes, they just had an increase in their cyclosporin target. They really didn't define subclinical rejection in their cohort. I kind of assumed borderline changes to be a surrogate, although not by definition the same as subclinical rejection. So looking at our baseline characteristics, these patients were definitely not the best matched. There were more male patients in the control arm. They were a little bit older. However, there were a lot less patients in the control group actually received basiliximab induction. That's probably the most important takeaway that I got from this. A majority of patients received standard cyclosporin, Cellcept, and prednisolone. However, a much higher proportion of patients in the biopsy arm received everolimus as their antimetabolite of choice. Looking at our protocol biopsy findings, only 4 patients were found to have borderline changes, which were all treated by increasing or optimizing their immunosuppression. 9 patients had BANF1A rejection. All of them were treated with pulse steroid therapy, and 4 patients were switched to tacrolimus from cyclosporin, and 5 patients were just increased on their cyclosporin. Looking at the post-transplant EGFR, there was no significant difference at 1.5 and 2.5 years. However, at 3.5 years, the patients that received protocol biopsies had a much higher EGFR than those that did not have biopsies. So what the authors concluded was that the use of 6-month protocol biopsies as well as targeted interventions had no impact on short-term allograft function. However, it had a significant benefit in the long term, greater than or equal to 3.5 years. So for our study, just to give a little bit of background, in 2011 was when a majority of patients were being transplanted over at University Transplant Center. So that's why I kind of said the program opens at University Transplant Center. And these were the majority of the patients, actually all the patients that we included. In June of 2014, we actually implemented a 6-month protocol biopsy and also drew a DSA level in the pediatric renal transplant recipients. So based on the background studies, as well as knowing that we implemented this new protocol, our research question was, has the implementation of these surveillance biopsies led to improved allograft function when compared to a historic control cohort? This was a single-center retrospective chart review of pediatric transplant recipients that were transplanted between 2011 and October of 2015. The reason we did that mainly was to allow for a year of follow-up. I did my data collection in October of 2016, so to give a little bit of perspective there. So our hypothesis was that surveillance biopsies at 6 months post-transplant would lead to an improved allograft function at 12 months post-transplant when compared to our historic control cohort. Our primary endpoint of interest was graft function. We looked at the peak EGFR, which was defined as an outpatient creatinine. It's derived from an outpatient creatinine measurement at 3 months post-transplant in comparison to a 12-month post-transplant peak. We also wanted to look at the absolute decrease in EGFR between that 3-month peak and 12 months post-transplant. And then we also looked at the mean percent change. We also looked at treatment for rejection between 6 and 12 months post-transplant in the control cohort, as well as a surveillance biopsy cohort from the timing of surveillance biopsy to 12 months post-transplant. We also wanted to look at our for-cause biopsy before that 6-month mark as well as after that 6-month mark. And we included patients that actually We only included patients that had surveillance biopsies done between 6 and 9 months post-transplant because many of these patients, when this protocol was implemented, kind of had a catch-up biopsy. So we figured that 3-month period might be a little too short of a window to see any beneficial effects. Our safety endpoints was the incidence of hospitalizations for infections at 12 months post-transplant. We also looked at the hospital admission as well as length of stay for surveillance biopsies. For those of you not familiar with the surveillance biopsies in our pediatric program, this is a 23-hour OBS visit, and we actually wait for the results of the biopsy. So the hope is to get these patients discharged before that 24-hour mark. And then biopsy-related adverse events. So inclusion criteria are our pediatric renal transplant recipients, as I had mentioned before, between January 2011 and October of 2015. We excluded patients that were adult as well as received the surveillance biopsy between 9 and 12 months post-transplant. So we had a little leeway in that 6-month mark. So our surveillance biopsy group received the surveillance biopsies. Control group did not have their surveillance biopsies. We looked at our categorical variables and compared them using the chi-squared or Fisher's exact test and continuous variables with the student's t-test and Mann-Whitney U. So looking at our baseline characteristics, from a statistical standpoint, there were no statistical differences between the two groups. However, in our our surveillance biopsy arm, there was a much higher proportion of Hispanic patients, although this was not statistically significant. Looking at our baseline immunologic characteristics, they were also fairly well balanced between the two arms. Majority of these patients were deceased donor transplants with a low CPRA and about 4 to 5 HLA mismatches. Looking at our primary outcome of interest with renal function between that 3-month peak and 12 months post-transplant, there's actually the control group almost did better than our surveillance biopsy arm. However, this was not statistically significant. So looking at our change in GFR from the peak, there was a higher percentage of change from the surveillance biopsy group in their GFR from their peak at 12 months post-transplant in comparison to our control cohort, and a higher proportion of patients had a decrease in their GFR by greater than or equal to 10, which is what we deemed as our kind of clinically significant decline in renal function. However, none of these were actually statistically significant with p-values being greater than 0.05. So looking at our other outcomes, there was no significant difference in terms of our for-cause biopsies between the group, as well as acute cellular rejection. And we actually had 2 patients in each arm that had infections requiring hospitalizations. Looking back at the actual data, none of these hospitalizations were actually due to, the infections were due to the biopsy event themselves. Many of them were just upper respiratory viral illnesses or bacterial illnesses. Looking at our surveillance biopsy findings, we only had 1 patient with normal histology on the surveillance biopsy. 5 had borderline rejection, and 10 patients had CNI toxicity, which looking at the data and going through the data collection, I thought was probably one of the most profound things that we saw. But when we look at how these patients were treated, only 9 of the potential 15 patients were treated for their surveillance biopsy finding. Fortunately, 4 of the 5 patients that had borderline rejection were treated with a pulse steroid regimen, a pulse soluble therapy regimen, and no patients had a increase in their maintenance immunosuppression, but 5 of the 10 patients that had CNI toxicity had a decrease in their maintenance immunosuppression. And looking back at these patients, many of these patients were actually an overwhelming majority, just thinking off the top of my head, were therapeutic at their prograph at the time of these surveillance biopsies. The reason that only 1 of these patients was not treated for their borderline finding was that there was kind of a little bit of confusion in terms of the pathology report, because the primary finding was borderline rejection. However, there was also some prograph effect as well. So basically nothing was done because the patient was therapeutic on their prograph, and they weren't sure that they wanted to pulse them because the borderline rejection was questionable within the report. Looking at hospital length of stay, almost 90% of patients had a length of stay greater than that 24-hour mark, or greater than or equal to that 24-hour mark. But one nice thing was that there were actually no biopsy-related adverse events related to the surveillance biopsies. So what we can conclude based on our data right now is that the use of surveillance biopsies in pediatric renal transplant recipients is not associated with superior renal function at 12 months post-transplant in comparison to our control cohort. There was a low incidence of biopsy-related as well as infectious complications, which is great. However, a majority of these patients had a hospital length of stay greater than or equal to 24 hours, which may have some significant cost implications. Some strengths of this study was that it is a fairly novel protocol in pediatric renal transplant centers. Many centers do not do pediatric renal transplant surveillance biopsies. As I had mentioned before, in the adult patient population, it's about 18 to 20%. In the pediatric, it's much less. I'd say only a handful of centers, anecdotally. There is potential for long-term follow-up data, so hopefully our incoming resident keeps up with, potentially I can convince her to keep up with the data collection to get some 2- and 3-year outcomes. However, this study is limited by its retrospective nature, has a small sample size of about 34 patients, and there was a lack of consistency of follow-up because some of these patients were transferred over to their primary nephrologists. Many of them were up in Austin, so we had to do a lot of actual kind of data integrity and making sure that our creatinine assays were the same for our measurements at 3 and 12 months post-transplant. So what I would recommend based on these findings is that we have some long-term follow-up because we would like to really see if there's an impact long-term. Based on all the data that we've talked about, and I'm sure I've bored everybody with so much subclinical rejection and treatment of subclinical rejection data, is that really we don't see our benefit in these surveillance biopsies, at least for looking specifically at subclinical rejection at 12 months post-transplant. All of our GFR benefits are seen greater than 2 years post-transplant in many of our studies. So long-term follow-up is definitely warranted with this study. Another thing that we can do that's actionable within our center is actually looking at our current processes to make sure that we're getting our biopsy results read as quickly as possible. If no treatment is warranted, getting these patients discharged as early as possible, because the fact that almost 90% of patients had a hospital length of stay of over 24 hours for this surveillance biopsy event definitely has some cost implications. I'd like to thank everybody that was involved in this study and is continuing to be involved in this study as I finish up my manuscript. And with that, does anybody have any questions? Yes.